ये प्रोग्राम स्टार्ट हो गया यहाँ पे। ऊपर थर्ड फ्लोर का ना, तीसरे फ्लोर पे लिफ्ट से। हाँ, उसमें देख, अंदर पार्किंग अंदर एक बंदा ही बैठा होगा, उससे कुछ भैया गोल गोल सा वो बता देना। लिफ्ट के अंदर पे आपके हैं। लाइन नेट से करते। एक जल्दी आ जाओ। सही बात है। अगले विषय के लाइफ मोटिवेशन पकड़ा है उससे नहीं पकड़े जो बोले वो है। ठीक है। पेट तो वही यूज कर लिया पेट। हेलो। वीडियो थोड़ा कम कर दिया। नहीं भैया, अगर लाइट लगाओ तो पेट में हो जाएगा। वीडियो को दिख रहा है बोले भाई नाम से यार। यार प्रोग्राम में दूंगा हमारे हमारे फोन पे भी दिख रहा है। बाइट कर दी मैंने हमारे ऑफिस पे हल्की कनेक्ट हो गया। ठीक पूरा है। ध्यान में डाला दबाया तो ध्यान में दबाया। फिर आगे लगना क्या क्या लिखा होगा। बड़ी सारी आवाज अंदर चार्ज नहीं हो रहा भाई। दूसरी वाला चार्जर का क्या दो बोर्ड में चार्जिंग आ गई है सारी। ये चार्ज हो रहा है दोनों। ये देखो बिहारी। ये देखो चार्ज नहीं आ रही ना यार, लिख कौन सी बेस पे हो। लिखा रखा है बोलिए चार्ज। ये देखो ना बिल्कुल आ रहा है। चार्ज नहीं सामने पहले क्या आ रहा है। ये भी चार्ज ये नहीं होगा। ये हो रहा है पर कुछ भी करंट नहीं आ रहा। चल तो नहीं वो आ नहीं ठीक लगा स्टेट को उठाई जोड़ा दो दिक्कत बेस में कुछ दो तीन बोर्ड तो खराब है तो काम नहीं कर रहा है भैया तो ये बोर्ड तो खराब है दो तीन में तो आई हो गया फिर भी मेरा बाबा अल्लाह अल्लाह एक फेस में भी नहीं आ रही दोनों बैटरी भी चार्ज नहीं हो रही 10 बजे से भी ये चल रहा है सर ये भी चल रहा है एक जो भाई ये इन दोनों में तो यहाँ किसी ने यार ऑन बैठ अब आया ये देखो ये वो डेंट अब बुला रहा तो नींद का तो रहना क्या सारा बंद हो गया मतलब हाँ हाँ टाइम क्या करते हैं Yeah. I mean, gradually instruction. Since I was, I became immediate. the floor of the mastocytic spiral. If the ingression is strong, it will lift up. If the ingression is strong, the mastocytic spiral is the lining with the apparatus. Please remember it. Lot of RCTs, lot of vitamin and neuralgia patients come to you only after they have got 5 or 6 teeth extracted from one. You know all that. Only then it is died. In the private clinic, private neuralgia, mammary sinusitis, mimicry, sinusitis, they are very, very important things which are discovered. Please remember that that's the management. The dining, if it is lifted up, please see that properly. This is the source of it. Very good case came. Last 3 4 days we have been working, and these are graduate, we got a guarantee award. We are going back now from the we have undergone the biopsy of which happened are you tell me that must be good stuff. Very the good stuff slips into the biopsy examiner. Patient came to us, looks like common child. This 9 years ago of the age, looks like a baby on the child. Okay, what do you see? You see something here? You see something here? He has no problem, but he has got his grievances about this patient. This history which has been caused in the lower half of the. Do you see this? This is what is documented by Subharti under the name I have written articles. Do you see this? So this mental fibrosity, you know this is mental fibrosity where also there is all the muscles come and converge here. This is hyperplastic also called as hypoplastic mental fibrosity. This can happen in children. So suppose a patient of this sort comes to you and he says, sit down, okay? Because it will further go and see how this point. Whatever you will do, otherwise it is set for it is too much of the patient. You can do a different explanation for the what that is. In the rare cases, we see that today in the mental disorders. How clinical ramifications except aesthetic. This can be more than this. And if we just, this is not how CBCT or controversy looks like. It's both cases. Like this. This is not documented in the book was done by a relatively few sources. How do you see this? Everybody knows this. It's something like talking about here and having one of this. Normal period about it. This is a hypertrophic period about it. And I need to know that it's not good because it's hypertrophic. You know that these muscles have very important role. You know the movement of the thyroid is such an important muscle that it not only controls your nose, it also controls your pharyngeal area for the airway. So people and speak back here. This is a very, very important muscle. Suppose the patient comes here in hospital and he has immediate further health. Immediate nature of it? No. You will do something else. Even some people they maybe trauma and probably they have no complicated take care of the children further danger is no one is here because of the hypoplastic series of the tongue is always going to be hypoplastic. Okay, so you have to take care of these things. What is this? What can happen? Molecular canal. Okay, like the child the pathway. Just to keep from the boom to the pathway. Now, sometimes these are eminent, and sometimes these are ingression for a lot of bacterial content. They need to close, but they never close sometimes. So, bacterial content more and ingresses. So, you know what it causes? It causes awkward caries. We had a patient We used to create manual the there is one which comes from here, the taking goes down, what is the data? Okay, manual of the department. Meaning the manual down. Sometimes we used to say patient is not illustrated and for a connector because they are nerves and there's a whole classification system there you are nerves. That is why the patient is not illustrated. Again, one is taken from a private practice. He had a practice. So you have to tell back in the nerves there. Okay. Now you have done. OPG round to see the color. OPG का reading development. ठीक है तो OPG is done what now he is there what nerve and the nerve is doing spread nerve the one is here and he is done it he has what seen this one amount of nerve in the nerve one let's outside. CCTV is not an option. CCTV is necessary to real estate. So everything humans understand our labor through report and as a report to the CCTV. And because we had everything I see and the patient has written a practitioner to report. So he's taken the CCTV report from us. Okay. Again, let me make it. There's already such a technology. We have some important. You just observe it, not read the surface. You need to read this kind of what is this? This is not no. You need to not access the knowledge, but this kind of knowledge. So that's the thing. So you have to after the what you have to do. You have to get this here. After that, no. Hmm. These are patients of analysis. This is how EMG looks like when it is. This is like how EMG like when it is. Almost problem with the EMG. This is needs to understand what it is. It is the same law. It is the same law also on the surface. It is a muscle which is like a mass. शादी शादी थी मोहन सागर में था सागर में पाँच दिया पाँच 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 बहुत बहुत श्रीनगर में चले गए जगह जाने मैं रात भर के आ गया चले मैं 11 बजे फ्री करता हूँ 11 बजे चले जाओ 1 बजे कार्य पार्ट को तो सुबह का मैं ना चार पाँच तो यस मैं बिहार में क्या तो उसका बिहार इसको एडवांस में क्या नाम से दिमाग को एडवांस दिए थे गजब है गजब गजब है सब यार इससे उठाया मैंने I'm not products. అంటే ఆగదండి. రాస్తే రాజేస్తా జల్దీ జల్దీ వాడి వాడి దాని क्या नाम है उसका? मतलब मेरे ये वो तो दूसरा वाला तो समझ में आ रहा है जैसे मैं बाइक पे बैठ गया वो बहना को चले पेट्रोल बैठ गया मैं बाइक पे मेरे कैसे Hello? नहीं आ रही थी वीडियो में आवाज नहीं आ रही देखो नेट रुक गया भैया नेट नहीं है बिजली में वो चल तो रहा है बिजली में बत्ती मार और तो चल रही थी चल लिया हो गया तो कितने मतलब आधा तो अरे आप नहीं आ रही हम्म? हाँ ये यार देवी हमको इसलिए सेव नहीं वो भी आगे से काम वही करता और फिर भी आ रहा है अरे नहीं लग रहा आवाज आ रही नहीं बिल्कुल भी लाइव में खुद देखे चला अपन बस मैं जो आवाज वो दिख गया वो भी इसमें आ गया तो मेरी आवाज भी पकड़ में तो इस लैपटॉप को वहां ले जाके रखते हैं हाथ तो ऐसा रखते हैं नहीं वो भी आता है ये मिक्सर है ना वो खराब है मैंने लैपटॉप Starting to change. Yes, ये निकालनी पड़ेगी मान लो लैपटॉप वगैरह ये तार खोलनी पड़ेगी आपको बस 5 मिनट उसके लिए तो वास्ते लगी हमारा तो the future for good and the business for the current after 2 weeks. So at first you can appreciate the more different present generation 3 7 and this is the result at 3 years follow. You can see how much change more is from when autonomous own well-being. Second is the casting and implant placement in the sensor. You can see that so 4 7 and 4 8 separate mobility and scale, extraction of 4 7 and 4 8 was done. 4 7 could not be used because of contact and spinning. 4 8 was used to 4 8 was used because something the block was prepared according to the protocol. And in the same section, implant casting. This is a follow-up of 2 years after grafting. Case 3, grafting and implant placement was done at the same section where you can see the root stumps here, root stumps were extracted, the implants were peeled, and the site was grafted. This is the result of 1 year after follow. Now, grafting and implant placement was done in different sections in case 4, where the roots were extracted, rounded according to the standardized protocol, the graft was prepared, the put in the socket, suture, again given to everything how much where is from without the collapse of the socket. As well as it is fully preserved and the implant was placed. Grafting and implant placement in different sections will see the data of 3 6. Then the implant was placed in this case, the one end was superadapted. So one end was extracted, the graft was prepared according to the protocol. It was placed in the defect site. It was placed in the defect site and appreciate the implant and the graft and how much more is regenerated. So this is a follow-up case of approximately 2 years. Case 6 is grafting and implant placement was done in different sections. So this was a case of vertical fracture in which the tooth was extracted. The socket was filled with autologous dentine graft and the implant was placed. Case 7, in this case was a grafting cystic lesion. It was a big cyst and after the partially erupted case was removed, it was amended according to the standardized protocol of making autologous dentine graft and the graft was placed in the defect site. In efficient, the graft was placed in the extraction site in the cystic lesion and this is the OPG. This is after 6 months and this is after 2 years. So what is the one-page property of matrix? That first of all, the property of dentine is it undergoes cyanosis. How does it help? This property helps us in by patiently during phase
one and two of healing. There is fast healing. It contains a lot of growth factors and DLP, which helps to generate new bone. There's also a regeneration. It has very bioactive molecules, the protein I just said, which helps in the acceleration of bone. And it has lots of factors that support bone modeling, and last but not least, it is autolocal. It has predictable acceptance and reduces better living patients with love. So what eminence can do for you? Provide you the peace of mind that your cognitive side succeed. You don't have to think whether my graph will work or not. It will definitely work. Provide you the peace of mind that your implant will maintain stability. Well, you will have implants ready side a bit faster than if you plant the normal zero graph or a synthetic graph. It will maintain the side dimensional aspect. The alveolar edge will be dimensionally stable as compared to the other graph. The patient will be more inclined to the procedure and it will reduce the cost of the drug. Thank you. Thank you so much, ma'am, for your kind words. Now, I would like to request Dr. Ashish Chandra sir, our head officer, Dr. Nancy Singh. Thank you, Dr. Ashish. I am Thank you so much, ma'am. Thank you so much, ma'am. Dr. Rastogi, from his hand, the Department of Cosmetology, Central Technical College. He is here to present our topic, Implementing for BDS on Decision Science.
Not many times we come across situations where we don't have time to wonder the more and we get confused whether child planner is the right choice. I thought of the topic for today. We will analyze the videos. The videos there right now. We will read. But it was one thing that is not successful. That means just everything is the side of the implant. So all these things will lead to intelligent failure or we have to go back and then we will have a procedure. So if we see the literature, number of surgical modalities including extraction of cylinders, occlusal bone graft, so it is expensive, bone graft is suggested for those kind of situation. So obviously we get out of this that particular modality
This is the art. So the absorption pattern of next lab. There is a high velocity that we have the same from the later side. So if we have the cable to the side, there is a possibility once the external one, there is a fracture of later cells. Then we have to go for a bone graft procedure, which is not avoid. So proper planning is required because I always say probably what is being the limitation of the technique is probably planning. We have not planned this well, and then later on we believe that technique is not working. It's wrong. So, respiratory technique can be of two types. One is single stage, as we suggest. We can have a location of the implant is placed. We do the quarter. Then, with the expanders, we expand to the desired stage. One stage to the next. This, so first is that is a single stage. So history of trauma, 1 is missing. So this is the OPG of the patient on the day one. So we can very well see there is no one there is only one deficiency in the web. So ideal case for me. So in this particular case, we have used South Korea Mr. Curie spreader to the frog. So after full flap is being raised, the corticotomy is being done with the help of the saw and then with the help of the spreader. Gradually and slowly we have expanded this two portion of it. So slowly and slowly we are opening the spreader and the spreader is creating a separation between these two parts. So once the desired separation is being achieved, we can appreciate that the desired separation is achieved between these two parts. So we need different tasks. So the each we have to actually want that desired separation. So this is the movie of the race cross and this is the hundred. Another case, again a single stage, the medicine that is see again you can see there is no vertical bone here, only there is defined horizontal direction. So we have taken CBCT for this patient. So as I said, the ideal case. So ideal case means we have to link as well as the of the cancerous bone. There is no RLAS net, so there is no concave. So the ideal case. Go for this case. This is so this is CBCT. Do what motion? Should I confusing this? Okay, so in this particular case, we have used the tension restrict okay, in this we have a saw to cause the particle, then we have a bone chisel that will cause the separation of the particle, and then we have a secretion spread, it will cause the desired expansion of the bone. So coming to this, so we have a full thickness slab raised, the saw part. So with the help of the chisel, the two plates is being separated. So this is the separation. You can very well appreciate that we are able to see that two particle plates separated from each other. And then with the help of the sequential experiments, gradually we have experiments more. So the key to the success for any risk-free case is the patience. So if you don't have a patience and you try to do it faster, failure of in the form of fracture of the so when we are expanding the whole patient, so every different does to be called 20 seconds of bone to get adapted to that excessive pressure. So once the sequential is so we can appreciate that we are achieving the right osteotomy. So the final osteotome, and then we have achieved the desired size of the implantation in the final implanted result. So once we see that cover screw is in place, now we see that there is a high jogging distance of more than 1 millimeter. So primary closure image. So this is the overview on table. We have taken the CBCT. We have taken the CBCT also to that particular place. So we can very well see in that particular slide that all the surfaces of the implant is in towards diagonal. So none of the single thread has been exposed. So both the label, but we have done the stage B, but we will just finishing our part. Full rectangle. Next slide. So we are creating the one what to fracture first. We believe that cortical plate is so hard that if we try to expand it on day one, there is a high possibility of fracture of the label part. So when this corticotomy is done, we will close the and send the patient back and recall after 3 to 5 weeks as per the age of the patient. So once patient 3 weeks, again we are infected. So once we will feel reflect we see that orthodontic but we have here callus formation. So technically what we have seen, we are creating a fracture in the bone and now we have left it for healing. So in 3 weeks, some callus has been formed. So callus is more flexible as compared to your cortical. So now we are the remaining of the process in second, then we are separating the two cortical plates with the help of the chisel and then with the help of sequential release, expansion. So more the expansion. Once we got the desired expansion, the implant is inserted. So once healing is done, so there was no jumping distance, we have not placed any graft. So once healing is done, so this is your OPG on the day 1 of the surgery, and then CBC. So again, you will see that all this of the implant is covered with the bone. So all the surfaces, labial as well as the femur, is covered with the native bone. That is key for successful implant. Next slide. So again, the figures show all the surfaces fully within the native bone. So once healing is completed, the second stage was done and impressions were made. And this is the final process. So there was a less space for 2 implants, but the more space for single tooth. So on 1 implant, we have given a 2 crowns. The 4 cases using an osteotome. So because when we have a deficiency in the quality of the bone, that is mostly your deformed bone, which is from maxillary region. So in that particular case, we have used Summers technique, which claims to retain the bone, recontour the lesion particle region, reduce heat generation, and also there is a reduced pressure bone loss because of less pressure on the bone. So this is how. So instead of using a tab, we are using a hand instrument to get the expression. So MIS bone compression it was used in this particular case. So, so first we have raised the flag. For pilot will be used. So since we don't have a deficiency in the width of the bone, the deficiency is in the quality of the bone. We have a D4 quality of the bone. So initially pilot will be used, and later on with the hand-driven instrument, sequential osteotome has been used to expand the bone or compress the bone laterally. We are not removing the bone, we are just releasing the bone. So this is how increasing the density of the bone and creating an osteotomy without removing. This is how people able to get to so to implants were placed. So once implant is in position, we got entrance stability, so we could make impression the implant should not take and within a week we will even covers. So this is our system. So these are the RBGs on day 1 and the OPG. Next slide. So after a week or 10 days, when we recall the patient, healing is fully done. Next. So these are the prepared abutments and the final process. Coming to case 5, that is with the osteodensification kit. So we have a specialized burr. So osteodensification technique was introduced in 2013. So this is a different concept in which the burr has been used in anti-clockwise direction. Normally we are using osteotome and other preparatory burrs in a clockwise direction, but in this we are using anti-clockwise direction. What we are doing is basically there is blunt blades which are not removing the bone, which is condensing the bone laterally. So once we are getting the condensation of the bone laterally, we are getting the density of the bone. So the advantage, we have increased primary stability and also we are able to maintain the integrity of the ridge without having any kind of effect. But this is found in the mandible. It is not a rapid one. Posterior mandible as well. So this is a case which is one of the cases for the dissertation of a postgraduate student as well. So bilateral missing six. So this is the CBCT we took the table to see the density of the bone in that particular region. And then on the one side, the full thickness flap was raised and the osteodensification curve were used. So we are using this curve, we are able to place the implant. And then we have made the impressions on the same day of placing the implant, and within a week, we were able to give the final prosthesis to the patient. So this is the final prosthesis, and the screw 10 crowns were given to the patient within a week. And then we have taken a post-op readings to the CBCT to see what is the change in the density of the bone. As company claims that we have condensed the bone laterally, so there is a possibility that we have a better density of the bone. So what we have found is we have measured the house all around the implant as compared to the conventional technique, and what we have found That as compared to the conventional technique, the density with the osteodensifications were a much higher. So definitely that particular technique works. So whenever we want to run any kind of a bone grafting procedure, we can definitely help these things. So to continue, we see that this augmentation, osteodensification, so the three techniques is basically a non-invasive methods of minimum invasive or a non-invasive method of getting a more. So to conclude, we will say to make beautiful visit the challenge is not to just press the key, but to know which key to press there. So this is, I think, will make you more interesting now. This I kept it for student. Earlier in our days, this pro, everyone heard the story of thirsty crow. So earlier in our time, say that Snow was considered to be the most intelligent crow because he has managed to arrange so many stones and to bring the water to a drinkable level. So I believe now we have a modern crow. So it doesn't believe in looking wasting so much of stones and he has arranged the straw and managing water from the same level. But now we want our students to be ultra modern. So we have found the ultra modern crow. So no need of vessel, no need to look for a water, no need to look for a stones or a straw. Directly to the source and drink themselves. So this is how we want our students to be accustomed with the new technology of the techniques and growing them. So with this, I would like to thank the God Almighty and my students for their patient hearing because I'm sure half of you are doing the same thing. Thank you very much. Yes, nobody is obviously the one through the direct principle and can be seen nearly the topic presentation relates from research for innovation. A concept that will is an innovation. Into a few students, faculty members, guests who are here. Uh, so this is my presentation today. Dental research-led innovation, a concept to realize in India. And this is actually an in-depth look at innovation and trends in dentistry, which are actually currently where they are available in our country. So as we all know that there's a saying that if we don't innovate, we will stagnate. And as Thomas Edison has very nicely put, there's a way to do it better. What we have to do is how to do it, find it. So this is the scope of presentation. Of presentation. What is the need for dental innovation? What are the steps in product development? Product development here means whatever device we are making, whatever we are innovating, then what are the regulations and policy guidelines? Who makes all those policies and guidelines for us? We are guided by all those guidelines. Then what are the funds and grants available? That is the most important for any research. You need money. So where is this grant coming from? Then where do the researchers, as a students, when you do your post graduation, you will be doing your thesis work from where your basic research starts. So where, and of course, then as you graduate on to becoming faculty members anywhere, you would need an infrastructure or labs or hubs where you will be working. So where this infrastructure is available to you, then how to do preclinical and clinical translation of this research which you are working on. Then where does validation and certification come from? Which are those government bodies? And then how do we translate that product, that idea which is there, into something which is marketable and commercialized? Who's going to do with us? So those are the industry partners. So we all know the great need of the hour is doing dental innovation. And this needs a collaboration with academia, the funding agency, and the industry partners. So, dental industry in India, it is basically it consists of the industry associations. Also, the dental market is available, and we are all dental surgeons. So, dentists, we are part of that. We are the basic part of that because we are the end users. And dentistry, we all know, relies heavily on the tools. What are the tools? These are the equipments, materials, and technology. These are the three things without which we cannot practice dentistry. So, what is the industry status? Indian oral care industry comprises only 5% of Indian healthcare industry. Medical device industry. Normally, these days, the government is promoting innovation of devices. Most of the researchers are working on innovation of devices. So this is composed of 5.2 billion out of $100 billion, whereas dental device industry, out of this $5.2 billion, dental device industry is the part given to dental device industry is 1.3, which is actually not much because dental product industry, we are talking about the product development. It comprises of only about 30% of the complete $1.3 billion, which works out to be about 40 to 50 $1 million. That is not much. This data that you see, it came from Indian Italian trade agency somewhere in 2020. So somebody was working and needed to bring out this data which you see here. So as I said before, this dental product market status in India, it is valued at 1.3 billion in 2020, and it is expected to grow at a compounded annual growth rate of 10 to 15%. So we are heavily dependent on imported dental products, and so mostly about 85% of whatever we are using, the products, the equipments that we are using in India, it is imported from countries like Germany, US, Italy, Japan, and China. So, as I mentioned, we presently cater to only 15% of dental product or equipment that is indigenous, that is made in India. And we have not a nice skilled human resource in our own country. So, what is required to be done is bring all that expertise under one roof. And this, because of this, we are importing all these equipments and products. This increases the cost of treatment to the dental practitioner, and so it leads to heavy financial burden all over to the dental surgeon as well as the patients. So, what is the focus area for dental innovation? The main domain of dental research is material research, equipment research, clinical technique, and software development. product development cycle. Again and again, this product development cycle terminology is coming. I hope to understand that it means a device development, which can be an equipment, it can be material development, software development, whatever. So these are the people who are involved, the clinicians, the academia, the people from engineering background. The government, of course, has to be there. The funding is coming from government. And of course, the industry partners, where they are going to help us to commercialize whatever research we are doing. So now how? The steps in product development. These are the stages of product development. First, we identify what is the need. Then the second stage is invention. That is, once we know what we are going to do, then is the concept generation, the idea. The idea has to come from us. And then implementation. The idea has to be implemented so that we can make a product. So first you see the need. What is the need in public? Then the prototype. You see that word prototype? That is a simple device which has been made, which can actually help us in knowing what is actually going to happen. And then this prototype is developed into a product after clinical validation and animal studies have been done. And then with the help of the industry, it goes into the market. It is commercialized. So what are the type of measurement system used to assess the maturity level of a particular technology? That is the stage of development. So you see this technology readiness level. This is the TRL. These are 9 in numbers, and this is step by step. How do we know at what stage our research is? So first is the ideation, the idea, the concept, which we as researchers are going to think about. Then comes the proof of principle. Here, the basic device design is ready. We have to design whatever we are thinking. Then we come to proof of concept demonstration, TRL3. The components of that idea we are developing. Some device we are going to make. So there must be some various components. We make those components, assemble, and then only that device will come. So that is TRL3, that is technology readiness level 3. Then we come to proof of concept establishment, early validation stage, where the Indian Standard Organization comes into play. All the tests, the quality tests are made. And then TRL6, the fully functional device is working. Then late validation stage is TRL7 and 8. After applying for pilot system is demonstrated and all the CEDESCO, that is what is the full form of CEDESCO? This is a board which gives us the licensing. This is the licensing authority. And then pre-commercialization and commercialization. Once we reach TRL 9 level, that means this is where the industry comes into play. It is marketable. So the changing ecosystem is actually enabling all it is providing an enabling environment for all the researchers to do research. So all these government of India schemes like Make in India initiative, Atmanirbhar Bharat, and this medtech ecosystem, this is medical technology ecosystem. This is acting as an umbrella to provide the infrastructure, the funds, the regulatory streamlining, the preclinical clinical support, health technology assessment, which comes from the Department of Health and Family Welfare, Government of India, and the policies and the guidelines. Who makes all these policies? Here, bodies like Indian Council of Medical Research is involved. So regulations and policy guidelines, I just spoke, and the funds and grants which are available. So funding opportunities, where do funds come from? You see, Indian Council of Medical Research, Department of Science and Technology, Department of Biotechnology, and Department of Health Research. All these come under Health and Family Welfare Department, Government of India. For people like students, young graduates and postgraduate students, these are the fellowships and grants which are available. You can always, when you are doing some research, when you go into your, if some postgraduates are sitting here, I'm sure you must be knowing, you have ICMR fellowships and grants. These are various fellowships and grants and schemes which have been put forward by the government for you to apply and get grants for your research work. As far as academicians and clinicians, the faculty members or anyone who wants to work, these Indian Council of Medical Research fellowships and grants, these are all the various, this is a higher level, ICMR individual and card grants, BIRAT, they call these grants are available. You can apply, you get through, you have the money. So infrastructure, apps, and pre-clinical and clinical translation. So where to develop this project? You should have some area where you can work. So these are the testing labs, pre-incubation setups, centers of excellence and research hubs. These are provided by ICMR and Department of Medical Research, centers of excellence at IITs and other medical institutions all over the country. They are there. And then we have the medical device parks. There's one medical device parks, AMTZ, which is actually located in Visakhapatnam, and it is government of Andhra Pradesh undertaking. A huge medical device park they have available at Swami in that place. So these are the resources. How do the researchers get resources? Where do they work? So these are the areas which are there in our country. ICMR, we have Search M Pragati at IIT Delhi. Then we have this Center of Innovation about just names. You should know where to go basically if you're doing any kind of research. Medical technology hubs under Department of Science and Technology, Department of Biotechnology. Then ICMR, DHR, all these are centers of excellence at IITs all over the country in Hyderabad, Chennai, Guwahati, Kanpur, Mumbai. AMPZ I just mentioned. This is a medtech, huge medtech park they have established and biomass centers. So validation and certification. Intellectual property right and product selling. What is that? Whenever you are generating an idea or concept, uh, you have to protect that because research is such a thing that today you generate an idea and concept. Somebody else might be working on the same idea and concept at the same time. And by the time after 1 hour, if you 1 year, if you have been successful, and they are successful maybe 10 months, 2 months before you, and they apply for this patent, then all your work is gone because they were the first people to reach that stage. So prior art search, this is you have to search that whether whatever idea you have generated or the concept you are thinking of on working on, is there any work going on in the country or even globally so that you don't have a setback later on. So this is an important aspect. So patenting of everything is possible. Normally, nobody patents their ideas and concepts. So, since we are, I will come to that later on, we also did not know about this. We came to know that you can do your patenting of ideas and concepts so that your idea is protected. That's what is intellectual property rights, protecting your ideas. And this is valid for 12 months and complete patent application after you have applied for a patent of your anything, your idea or your device, whatever you have done, you get the certificate after 1.5 years. So this is what I was talking. Ideation, idea, then prototype, development, and then manufacturing and commercialization of whatever prototype you have developed. So CEDESCO, I was talking about CEDESCO. This is the regulatory compliance. This is Central Drug Standard Organization, control organization. And you have to apply to this body to get all the compliance. You have to comply with, they have a lot of rules and regulations and guidelines. You have to comply for that. You have to go through all this process before you can proceed for clinical trials and animal studies. Even online platforms it is now available. So what is basically a research hub? Research hub is it is creating a network for dental technology development amongst the academia, the funding agency, and your industry partners. So if what is the role of academia-based innovation hub? It acts as a resource center for dental technology innovations. It acts as a facilitator for your IPR, I just spoke about it, and regulatory clearance. It facilitates. It acts as a training center for product introduction, then product translation from your idea into the device which you have visualized to be commercialized, then validation, the CEDESCO body here, it helps. And then another very big role is connecting us, the academicians, with the industry. We have no direct connect except as we are the buyers. But whereas the research is concerned, it's a different ball game altogether. So the first dental technology innovation hub has been established at Maulana Azad Institute of Dental Sciences under the aegis of Department of Science and Technology. And this is just a glance into, we have equipments. This is the team which is there. These are the facilities. These are the equipments. We have already purchased, a lot of equipments have already been purchased and some are under process. So this is the DTIH, Dental Technology Innovation Hub at Maulana Azad Collaboration Network. The hub has been working on this since more than 3 years now. And the academic institution, this is already established. This is how you're going to work. Otherwise, it doesn't happen. So there are 30 people, industry partners, 14 dental technology hubs and manufacturing industries. That means these are only majorly three in our country. Medical technology. One is at PGR Chandigarh, one is Anmol University in Chennai, and one I mentioned was AMTZ, that is Andhra Pradesh government. These are the 7 technologies already incubated. Indraprasth University in New Delhi, Chennai, Pune, then IIT Mumbai, IIT Delhi, and Maharashtra. This is just a thought. Dental innovation, it can come through new combinations. We don't have to travel on the same path. There are so many things coming in, so many collaborations with so many people, non-dental background, engineering background, to develop products and new processes. So this is the ABCD. Summarize. First, you have to assess the need, whether it is of any use to the public. You have to be patient. It takes a long time to do any kind of research. So perseverance and persistence, that has to be there. Then collaboration. Team or the power of teamwork. Anything is possible. And the design. Design should be such that it should be acceptable to the public. That is very important. Otherwise, things don't sell. Thank you. Session. Now, we have come to our chief agency, and speed our students. I would like to talk. Before that, let me ask one question to the guest, please. Ma'am, you have shown so many good facilities which are available in your center. Are they also available for people who are working in other institutes? At the moment, we are in the first stage. Seven, I told you, seven technologies have already been incubated. So the grants have come from Government of India funding agency. This hub is a facilitator. The grant comes, and then all that money goes into the account of the principal investigators who are working on those technologies. So it is a structured thing. Anybody can't just walk in into it. So maybe in future, if any other scheme comes under this hub, maybe we can invite you. Yeah, they'll be very much useful if sure if they are being allowed to us. Thanks. Thank you. When the light from the leaving the bathroom, thanks. Usually, I think I'm both on. What do you mean? So much. So, emotion. Starting with track, that micro sets the confidence right, and environment right. With this thought, I would like to move on to the next section for today by Dr. Anmol Bagaria, who's the professor, head of the department, Dentistry-now, at Civil Dental College, Rishikesh, Uttarakhand. Let's talk about today, please. Great comment. Crowd poetry. Province. Following the constant Dentistry and Independence. Senior Dental College, Rishikesh, Uttarakhand, has stopped on very few accountability.
Uh, Good morning. And it was a very nostalgic moment for me, Jatin here, because I started by teaching. That is, I joined this institution as a lecturer way back 25 years back. And the place where I am standing
was not the lecture hall at that time. The department remains the same, but at this place we used to have uh, the sun bath in the winter season, and then we developed slowly, and the lecture hall was made. So thank you, Principal Sir, Bharti College, Vanita Ma'am, and the CynoDent for giving me an opportunity to present my views in endodontics in this college. And what we are going to talk is something very interesting because it's a great day to start to learn something new. And we have to break the myth that does all endodontically treated teeth or the root canal treated teeth require crowns. We all love endodontics. We all love to do the root canal treatment. Whether we are undergraduates or postgraduates, we just love endodontics. And when we talk about endodontics, we not only talk about the filling of the root canal, but we have to understand that completing the root canal treatment is not the end of the story. It is not the end of the story. The tooth needs to be restored back to the normal function, form, and aesthetics. This is the fundamental objective when we work with endodontics. And then what next? जब हम root canal complete कर लेते हैं, so the immediate mind, the thing which comes to the mind is what next? And we tell the patient that please come for the crown. Crown is the next step. Then we always talk about the crown, and we always believe that the root canal treatment, all root requires crown. Because of the fact that we have been taught that the all endodontically treated teeth, there is a reduction of collagen bond in water, there is an aging of the collagen, and then there is a change in the properties such as the young modulus, the dentin hardness, and the fracture resistance. We have been taught that all these, the endodontically treated teeth or the root canal treated teeth becomes weak, and that is why we need to place a crown. We always used to believe about a straight line SS cavity preparations. And when we were talking about a straight line SS cavity preparations, we were told very simple step. You take a round burr, when we talk about the molar endodontics or premolars, you take a round burr, you place in the center of the tooth, you take a straight fissure burr, you move around the corners, and then we get a good straight line SS. Probably because we never emphasized on the use of magnification in the form of the loops or the microscope, and also we never emphasized on the residual dentin thickness. There was no concept of the residual dentin thickness, and we used to cut a lot of dentin. So this concept of the residual dentin thickness never existed, was never taught to us. And we used to believe that the straight line access is the mantras for the successful endodontics. But now, when we talk of today's endodontics, sorry, when we used to talk about the endodontics, we used to talk also that we need to have a good meters of the dentin around the tooth so that after completion of my root canal treatment, I can do a good crown preparations. Because we had a concept in mind that all endodontically treated tooth requires crown. But the big but is the technology has changed. Everything has changed everywhere, not only in dentistry but around the world. And we are moved probably because we now believe a lot of we work under magnifications and we lay a lot of stress on the residual dentin thickness. Residual dentin thickness is the one, or the RDT is the one which we lay stress. And then when we talk about the RDT, we talk again of this phenomena. When this was what we were taught, reduction of the collagen water and the aging of the collagen. However, many studies have now completely stated that there is no change of physical properties as far as the modulus of elasticity the dentic hardness, and the fracture resistance is concerned. So this is how the concept has changed. And then we have moved from a straight line assess cavity preparations to something very interesting, that is the orifices directed assess, where we lay emphasis on the residual dentin thickness. Lot of dentin preservation is stressed upon because probably we are working with magnifications, either the loops or the microscopes. So when we talk of the intake in the endodontics, the orifices directed access, you just need to have a good armamentarium. You don't move around the corners. We don't bleed in the concept of 2 millimeter margins around the tooth. We just move towards the orifice, and finally, we have a complete balance between the conservation and the essence, keeping in mind to maintain as much of the dentine as possible, that is the residual dentin thickness. If you have a look at how the things have changed, this is a standard access cavity preparations where we used to have a round burr. We used to in the central incisors, we used to go into the cingulum area. Then we used to extend our access cavity preparations. But the conservative access cavity preparations have revolutionized the way we look at our endodontics. So if I work on the central incisors, this is my access cavity preparations. There I have done a good shaping, cleaning, and a three-dimensional observation of the whole system. So I can easily fill this part with a restorative material in the form of a composite. And I have got a good residual dentin thickness. So where is the need for the crown? We don't need a crown in these cases. So this is the access cavity preparations which we were talked about to move around the margins. The things have changed. More of a dentin preservations, more of a dentin preservations, and then we have something like this, the more of a dentin preservation. So when I have so much of dentin, I don't need to place any crown. Look at the access cavity preparations, the premolars, access cavity preparations in the molars. We have lot, and we can just top it up with the posterior components. See the amount of dentin. This much amount of dentin we have preserved. When we have so much of residual dentin thickness, if we top it up the composite without any need for the crown. So zone of preservation is the end thing in endodontics. We have to preserve as much of the dentin as possible. And residual dentin thickness is the mantra for a successful endodontics. Now, when I talk about the endodontics, we talk about the access cavity preparations, we talk about the restoration part. And when I talk about the restoration part, I have a big question. The question is how to proceed. I have completed my root canal treatment. Should I go for the I should go for to look for the degree of stress which is experienced by the tooth under load and the biomechanical property of the remaining tooth structure which is responsible for resisting the fracture. So these two parameters I have to look into considerations, and also I have to understand the structural integrity of the tooth, what is the structural loss, and then how much is the pericervical dentin loss before I decide how to proceed next. So when I talk about the structural integrity of the tooth, it is a very important factor because it determines the prognosis as it relates to the post-endodontic survival rate of the tooth. Also, I need to understand the maintenance of the strength and the stiffness that resists the structural deformation. So when I talk about all these factors, I need to understand, should I go for a direct restoration or should I go for the indirect restorations? So if I go for the direct restorations, we lay a lot of emphasis on the coronal restorations, immediate coronal restorations, because we believe that a root canal therapy needs a good restorative treatment, which is also critical and crucial for the success of my endodontics. The quality of coronal restoration has its effect on the survival and the success rate of endodontically treated tooth, and then
Why the coronal restoration is very important? Why it is very important? Because the research says that endodontically clinically with adequate coronal restorations have a high success rate compared to the poor quality. The well-sealed coronal restorations will prevent the ingress of the microorganisms. And also, coronal leakage is a major factor leading to the endodontically treatment failures. So that is the reason why coronal restorations are very important. And when we talk about the coronal restorations, we talk about the direct restorative materials. And the direct restorative materials are in the form of the composite resins or they are in the form of reinforced composite resins. The composite resin is of course the material of choice because of all these properties and the best is compressive strength which is better as compared to other tooth color restorative materials. Now, how to do a coronal restoration? It is very simple. You just need to have understand the basic steps. So, if I have completed if this is the clinical situation, we remove all the caries and we just do all the steps we do in a normal composite restorations. That is, we etch, bond, we apply, and we top it up with the posterior composite. So when I do with the posterior composite, I don't have to think about the crowns in this stage. So all the crowns are completely eliminated. And this is the final restoration. A direct restorations. Now when we do these type of direct restorations, we eliminate all the problems which are as the crowns because no laboratory can give us a good contact in the contours. That is totally eliminated. Then, if you are talking about the interiors, clinical situation, something like this, I don't have a place. I don't have the dentine to place a crown. And we have a lot of materials in the form of the fibers where immediate placement of the fibers and immediate build up with the crown, with the composite. So where is the need for the crown? You don't have to place a crown. Then we think about the indirect restoration. And when we talk about the indirect restorations, we talk about one important factor that is the pericervical dentine. And when we talk about the pericervical dentine, it is an irreplaceable critical most zone which is 4 millimeters above and 4 to 6 millimeters from the crestal bone. And it is very important to preserve in order to prevent the fracture of the tooth. Now, when we talk about the crowns, we talk about significant removal of the natural tooth structures, which weakens the tooth and makes it more susceptible to damage. So, when I talk about the long-term effects, the crowns have an effect on the gum, they have the wear and tear, they have an effect on the maintenance. So, these are the disadvantages when we talk about the crowns. So, what are the alternatives we have when we talk about we have the inlays, we have the onlays, the overlays, and the undercrowns. So this is something very interesting and in the restoration. We have the composite inlays, we also have the inlays, and then we can also have the undercrowns. So we preserve the dentine. We have a very significant dentine which is present, and this preservation of the dentine is very important for the success of our post-endodontic restorations. Now, how to decide what type of restoration I'm going to do? So you have to consider the following factors, that is the severity of the tooth damage, the aesthetic and the cosmetic reasons, then the risk factors and the cost and the maintenance. So all these factors play a very important role in determining what type of post-endodontic restoration I want to do. And if you look at this chart, we have the minimum destructive peak, so we can talk about the intracoronal composite restorations. You have a moderately destructive peak, you can talk about the overlays, and when we have a severe destructive peak, we can talk about the fiber post crowns, or we can even think about the endocrowns.
If you compare between the inlays and the onlays, a very conservative approach as compared to that of the crown. Now, when I talk about the survival rate, the inlay survival rate over a 5-year period was 95.89%. The only survival rate was 93.50%, compared to the crown was 85.38%. So that is the reason why inlays, the onlays overcome the disadvantages of the crowns. So the my take is the conservation of the tooth structure is very important when we are working in endodontics. The inlays and the onlays they require less removal of the healthy tooth structure as compared to the crowns. The crown necessitates more extensive tooth preparation, probably potentially weakening the tooth in the long term. Also, the inlays, the onlays, and the undercrowns they offer the adequate strength and the durability. They can be made to match the color and the aesthetics. We have the cat cats, we have everything now as far as aesthetics are concerned. So why should we think about the crowns? हम क्यों चाहिए पीछे? Why we think about the crown? Don't have to think about the crowns. To win the game, we have to remain in the game and we have to think what next after endodontics, after root canal treatment in the form of direct or the indirect restorations. So this concept, whether it's a love marriage or the arranged marriage, the goal is the success in endodontics. The same concept is whether I go for the direct restorations or whether I go for the indirect restorations, it has to be successful for a period of time. And therefore, to conclude, you need to think more of direct and restorations. You need to think more of the inlays, the onlays as counts when we talk of post-endodontic restoration. So where's the Josh? The Josh is to think about the new technologies, to think about something new when we work in today's endodontics. And before I conclude, I would like to say only one thing. Please don't think about the crowns at this stage. You have to really come up with something interesting in the form of inlays, the onlays, the post-endodontic restorations in the form of the composites before actually go for the success of vertical thread. And I would like to acknowledge my postgraduates for for helping with this presentation. And we are in the festive mood because we have the Holi next week. So, on behalf of my conservative department, that is from Sima Dental College, I wish you all a very happy Holi. And I thank you all for a very patience. Thank you. So, was a wonderful session. And now, our interview now. I would like to follow by the next progressing. It's still collaborative, cultivated thinking, and development. Smart requires the shared term. I would like to learn like more about and the way Ashish Chandras and our job. But the many also volunteered, which is really not the world. From the little babies, we are in the water. Nature college, good luck. Now I'm to Dr. Manish Kanti Constant criminology, currency, and the severe character of data elements. Maybe it's human here. I would like to call for a additional reason for the felicitation. Yes, only. Thank you. Welcome. Welcome back to call Dr. Anshali sir for presentation. Dr. Anshali sir, professor and in charge of Department of Oral Immunology and Microbiology, Faculty of Dentistry at Jamia Millia Islam. Can we have a round of applause? So, because is what this graduate from the Kazakh Institute of Medicine, Delhi, and with master in Panorama from College of Dental Sciences, the Boundary in 2001. Still, he's an active involved in academics and training programs for undergraduate and postgraduate dental students, and currently heads the Department of Periodontology in the Institute of Dental Studies and Technologies, Mumbai, Uttar Pradesh. So I have to start my presentation as a good morning, but now it's good afternoon. So good afternoon to you all. So that means you are not sleeping, but a more louder one. Good afternoon. Great. So it has been always a pleasure to come to Subharti. I have been here a number of times. To begin my presentation, I would like to thank God for showering His blessings on all of us. I'm thankful to CynoDent. This is the third or the fourth time I'm speaking in CynoDent. I'm thankful to Dr. Anmol, Dr. Ashish, who are my student as such. But it's great always to come to CynoDent and deliver some lecture. I'm thankful to my undergraduate college, Vivekanand Institute of Dental Sciences, and I'm privileged to share the stage today with one of my gurus, Dr. Sangeeta Talwar. Uh, MAGE was one institute which inculcated the art and science of dentistry in me and made perio so interesting at that time, so much so that I landed up in College of Dental Sciences, Davangere. Dr. Vandana, she was my guide, is my guide, and will remain a guide for me forever till she's alive and I'm alive. Uh, I'm thankful to IDST. I've been working in IDST for the last good 18 years or so. I'm thankful to all my perio staff. One of them is sitting here. I have 11 staff members with me. I'm thankful to my family. These are the times when I'm busy with my profession and my family is enjoying their life to the utmost. And they say, okay, you enjoy your professional life, we enjoy our life. And these are the times which I relish the most when I'm with my family, I'm with my kids, I'm with my wife. So these are very memorable moments for me. So there has to be a balance between your professional and your personal life. So, I suppose most of you are undergraduate students. Yes? Yes. So, for you, what is period? What is period? Sure, treatment aspect. I'm not talking about the theoretical aspects. Scaling, good clinic. Fine. So, when I was in Wales, so the period department was known as the Subsidy department. So we are honored to be the Safai Karamchari of dentistry because it gives something. Let's see what. So that's why my title is looking beyond the customary. Customary is what? Scaling and root canal, cleaning of the teeth. We all know this. What periodontium is consists of two hard tissues and two soft tissues. What are those? What do they do? What is this? First year. First year thing. What is this? Developing skull. What is this? What is this? What is this? What does it do? Backup of a. So similarly, periodontial is the backup of the tooth. It makes the tooth stand. Let's see how. All dental treatments, they are possible on a good foundation, and this good foundation is provided by periodontial. So if there is a good periodontial, this is a photo from the nail. But if this is a true fact, then a single implant tooth is having the load of these 12 teeth. So that means this is basically a Ramana tooth. But if the periodontium is healthy, this is what we can attain. This is my own patient, my clinic patient, and privileged to have my prosthodontist here today, who has shared the stage today early morning. Uh, for this patient, we have done an implant in the upper one. Now we are going to proceed for the lower one. But these 4 teeth have been taking care of these 12 teeth for the last 8 years or so now. So if the periodontium is healthy, these wonders can take place. A healthy periodontium. What does an oral medicine guy see once you start doing a diagnosis? You see basically the gingiva, you see the oral mucosa, which are part of the periodontium. Orthodontists cannot move a tooth if a healthy periodontium is not there. Moving forward, backward, upward, downwards are all possible with the help of that ligament, which is known as a periodontal ligament. And if that periodontal ligament is not healthy, the orthodontist will never move a tooth, he will never do braces. Prosthodontist will never do a crown cutting if the foundation is not healthy. That means if the tooth is not having a healthy periodontium, the prosthodontist will never do a crown cutting. We need a healthy periodontium for that. For a successful implantology, you have been in and out for the last 2 days on implants. As both Dr. Mayur, Dr. Ahmed have been talking about implants. So if you don't have a good bone structure, you cannot place a good implant. And here again, a healthy periodontium or a healthy bone is needed. An endodontist would always see the periodontal ligament space before beginning up with the root canal. If it is seriously exposed to, then there is a breach in the periodontal ligament space. The endodontist will straight away say do a root canal. So again, periodontium aesthetics. It is just the white which makes a good aesthetics. It is a mix of the pink and white which makes a good aesthetics. And the pink is what? Periodontium. Pediatrics, all these things in a pediatric patient. Extraction. Just imagine if there was no periodontal ligament, how difficult it would have been to take a tooth out. So again, periodontium. So here is what periodontics or a healthy periodontium can do. So a healthy periodontium starts at home with good oral hygiene practices, the various oral hygiene practices, and if these are not maintained, plaque and calculus will start accumulating, and this plaque and calculus will lead into 2 inflammatory conditions, which are gingivitis and periodontitis. Just inflammatory conditions, and the outcomes are these: changes in color, bleeding, changes in size, texture, recession, pocket, and mobility. So why do patients come to the dentist? They just come for functional and aesthetic dentition. And the most common disease causing these aesthetics and functional compromise is and leading to tooth loss is what? A periodontal disease. The prevalence of periodontal disease is 70%. That means 7 out of the 10 patients who are entering our clinics have periodontal diseases, and most of them go unnoticed because, say, we are not trained to diagnose those diseases. And the second thing is they are trainless and partly ignorance because they are not trained. And the net loss is for both the patients as well as the dentist, because if you are able to diagnose and treat a periodontal disease, believe me, you would be a multi-millionaire. So, our ultimate aim is to diagnose at the right time, and if we are able to diagnose, we are able to provide an excellent treatment plan.
Our diagnosis is not just to delay the death of a teeth or extraction of a teeth, but we have to increase the quality of the life of the patient by giving him a functional dentition. We have to have a recall visit if we have to prolong the life of a tooth, and for these recall visits and a proper diagnosis, we have to be prepared to diagnose a periodontal disease. The most easy armamentarium to be added in our practice is a periodontal probe, which most clinics are not having. If you have a periodontal probe and you know how to do a proper probing, you are able to diagnose a periodontal disease. Probe is an eye, and if you have probe and you know how to do proper probing, you get strange clues like this. Clinically, if I see the gingiva might be healthy, but once I probe, see what's the probe in there. Once I probe, good probe in there. If you have these types of OPGs or IOPs and you don't have a probe, everything goes wrong. If you have a probe, this was an article given by a very dear friend of mine who was an editor of the Permanent Index Journal. An 8 millimeter pocket that wasn't a 3 millimeter at one time. So that means the pocket can, when you are probing and you see a deep periodontal pocket, that has not reached to that stage in a single day. And if you are able to diagnose and treat at, you are able to prevent the periodontal disease. Untreated disease leads to loss, and today the periodontal disease continues to be the leading cause of tooth loss. So much so that Time magazine in 2004, they said that this inflammatory disease is a secret killer for n number of systemic diseases also. And now periodontal disease has been related to n number of systemic diseases, most commonly diabetes, pregnancies, lung diseases, cancers, heart diseases, strokes. So much so that periodontal disease has been labeled as the sixth complication of diabetes mellitus. And on the recommendation of the Indian Society of Periodontology, the Ministry of Health and Family Welfare has made the periodontal examination compulsory for all the pregnant females. The link is so much so established that we as dentists are now known as oral physicians also. The goals of periodontal therapy are to preserve the natural dentition and the periodontium. Scaling and root planing is just the beginning of that treatment. It is the cornerstone, the first line treatment. It effectively decreases the bacterial load, decreases the inflammation, and improves the gingival health, plaque score, and active bleeding sites. It gives immediate visible results if done properly. It is not just the supragingival scaling. It has to be a combination of the supra and the subgingival scaling. And if you do a thorough scaling and root planing, you give immediate visible results and prompt relief from bleeding and inflammation. But what comes next to this scaling and root planing? The other periodontal cases which are encountered except the accumulation of the plaque and calculus, few of those are trauma from occlusion, the accretion, abrasions, abfractions and erosions, pericoronitis, hyperplasias, drug-induced enlargements, pregnancy-induced enlargements, pyogenic granuloma, puberty-induced gingivitis, primary hepatic gingivostomatitis, necrotizing diseases and squamous cell carcinomas. So these are again diseases which are treated first, except the carcinomas, which are perico and an oral surgeon can treat combined. And these are few of the procedures other than the scaling and root planing, which are most commonly done by a periodontist. The local drug deliveries, splinting for mobile teeth, which can be the wire and composite splinting, or just a composite splinting or a fiber splinting. The minor surgical procedures include splenectomies, deep indentations, crown lengthenings, and the surgical procedures includes the clavicular flap surgeries, modified treatment flaps, scapula preservation flaps, regenerative surgeries only with bone grafts, or a combination of bone grafts and GTR membranes, bone grafts and PRF membrane, which is also a GTR membrane. And this case was done in my department. This was the situation initially. We had done the grafting, and later on, the orthodontist had taken the advantage of this pillar as a retention tooth and did his ortho treatment. So, this is the X-ray of a 2-year follow-up X-rays of that patient, the bone loss, and at the end of 2 years, once the ortho was completed, the bone support. Then the other procedures includes the root resections, the periodontal plastic procedures to cover the exposed root surfaces, the single tooth recessions, the lateral pedicle grafts, the Carnot technique, the coronary advanced flaps, the free gingival grafts, the connective tissue grafts, and for multiple teeth, the Vista technique, which is used to cover the multiple teeth recessions. The vestibular deepenings, lip repositioning, but we should know that we are not God. We cannot do all the things together. We should not go in for this thing, which is can do all technique. We should always go in for a team approach and remember this that हर एक friend जरूरी होता है, especially for the periendo cases. Few of the periendo cases, we cannot do it ourselves. It has to be a combination of an endodontist and a periodontist. These types of cases, until and unless a root canal is done, the same case which I was talking about, if you have this type of a case, first the root canal has to be done, then the perio treatment has to be done. Again, perioendo, deep periodontal pocket involving the periapical areas, and endo treatment has to be done first, followed by the periperio treatment. Perio-prosto interrelationship, you do crown lengthenings, but keep the biologic width into consideration. Do group crown lengthening procedures for the support of the crowns and help the prosthodontist. Do vestibuloplasty procedures for good retention of the dentures. Enlargements in cases of orthodontic treatments are quite common, enlargements and recessions, but a good team approach, a good combined perio-ortho relationships can treat all these recessions and the enlargements and prevent the retention and relapse in ortho. Periodontally accelerated orthodontics is a new technique. New means now it's quite old. You have to have a combination between an ortho and periodontist so that we can accelerate the ortho treatment. We can decrease the ortho time by taking advantage of the periodontal issues. Some of the iatrogenic factors and overhang margins, violations of the biologic width, open contacts, all these are a combined efforts between an endo, prosto, ortho and a periodontist. Aesthetics dentistry, most of us put our clinic labels as aesthetic clinics. These are the dental clinics and aesthetic clinic. But mind you, aesthetics is not that easy. And unbalance between the pink and the white is aesthetics. White aesthetics has no role beyond the CJ. Treating recessions only with white aesthetics leads to long clinical crowns. If there is a recession, there is an exposure of the CJ. The most common procedure what we do is we do light cure restorations or GAC fillings. But it leads to long clinical crowns and compromise the aesthetics rather than restoring them. So if we plan, we have a balance between the pink and the white. then we can lead to excellent aesthetics. Implants, they are the newest pillars. You have, I think most of you would have done the pre-conference of implants, but for implants, I have this saying: success has many fathers, but a failure does not even have a mother. Implant is not that easy to do. If an implant is failed, if you are doing an implant and it gets failed, remember an implant patient always marries you. You would be a husband or a wife for an implant patient. So वो तुम्हारी जान खाएगा वापस आप. So as I told, is prone to periodontitis. Implants are prone to periimplantitis, and you should be aware about periimplantitis and know how to treat periimplantitis also. Failure is the opportunity to begin again and more successfully. Don't get disheartened if your implant fails. Do it again. Lasers. Dr. Sharko, I think, has taken an extensive lecture on lasers, so I'm not going into details of lasers, but these are the few procedures. The soft tissue laser in perio, we can use it for operculectomies, we can use it for pocket eradications. There is a procedure called laser assisted new attachment procedure. Then you can do it with a photodynamic therapy in which you inject a dye and eradicate that with a laser. We can do canine exposures for helping the orthodontist out. We can use lasers for second stage implant surgeries. Once we are exposing the crown, we can use lasers. And in the end, I would like to say that dentistry is not expensive. Neglect is. Love your teeth, love your gums, love perio. Thank you so much.
Thank you so much, sir, for your kind words. Now, I would like to call Dr. Aman Chaudhary, sir, Professor and in charge of Department of Rural Technology and Microbiology, Faculty of Dentistry at Chanakya Media Scotland, to present on the topic Poets Odontology, Past, Present, and Future.
There to give you a, you have been listening to a lot of implants, a lot of labor, a lot of fillings, a lot of things which might be your bread and butter for next few years. So what I'm going to be talking to you is totally off track. I am Professor Aman Chaudhary and I have been dealing with this topic for around 12 years now and I have been investing a lot of time in it. And to promote it and to tell you the importance of it, it will be a part of, it is not a myth now. It is a part of uh, NDC is part of the curriculum now. And if you would have seen Schaefer's third year, it has a chapter, one chapter by Dr. Ashit on forensic odontology, which might be an entire subject in near future. So I thank CynoDent for giving me an opportunity to talk to you all and promote a certainly a little name or a novel subject, which is forensic odontology. It might lead to a lot of opportunities for you. It might lead to employment. It might lead to, some kind of research. You might get grants, and you will see my journey has all that in that. So that's my training. I was trained by Indian Board of Forensic Odontology, the name which I said IBFO. And then I was trained at Patiala for 2D reconstruction, 3D reconstruction at Central Forensic Laboratory, Chandigarh, and then was at Tübingen University, Germany, where I was trained for facial reconstructions on cadavers and dead bodies. So, lot of science which can evolve. The anatomy which you learned in first year, the third year pathology which you learned might be very handy here. Manipulation of dental materials, whether it is modeling wax,
mixing of alginates. Now, this all appeared rocket science for people who are from forensic medicine and forensic science. But for me, it was a child's play because I have been trained for as a dentist for all these materials. Talking about what is it? See, I'll be really skipping through. I'm keeping you away from lunch, I guess. So I'll be very fast and just giving you an overview of what goes on in forensic odontology. Now, this an overview how to see it in forensic odontology for dental practitioners, for students, for academicians and research, and what is the road ahead. So, have an overview. What exactly is you or Meerut? Anodon, a thecodon, and a heterodon. Heterodon means we have two sets of dentition. We have a primary. I know everybody is clear about that. We are not having tertiary dentition. Thecodon, we are the all the tooth are lost in the socket. And third, heterodon. We have various types. You were taught traits, type traits, and you were all your life was really troubled. You were asked which is a premolar, what are the traits, what it looks like. So there can be metric and non-metric traits also, and that can lead to a very important identification through teeth. So history. This gentleman is called the father of forensic odontology, Oscar Amido. If you read his book, I have been lucky to be visiting Paris, Chad, where the book was written. This gentleman wrote anthropology book. To surprise, you will feel so proud because you are knowing Rich, you are knowing Singulum, you are knowing Fossa, you are knowing Pit. The description what he gave was mountains, valleys, dips, torturous courses. So, you are well equipped in communicating. So, imagine maybe so 18th century, the end of 19th century, the science had not developed that much. So we are equipped and we are using notations for talking to each other. We know Zygmunt Palmer, we know Universal, we know FDI, and we know fourth one. Anybody? Fourth nomenclature system? Victor Hardrep. Now anthropology uses Victor Hardrep is the system which is used. So this is Hitler's teeth, this person created his own clones. And, for 20 years, it was thought that he escaped through a route to Austria and the dead body which was found was not correct. So it was proved by Russian scientists who had the Russian dentist who had the bridge work, the details, and that matched with the dead body. It was excavated again and it was matched and it was thought. Same was with Saddam Hussein. You know about this Ted Bundy case. Ted Bundy is a series in Netflix. Please go ahead. Gross. He left bite mark on Levi's body, and that's how peculiar it was. Uh, Talking about WTC, what is that? World Trade Center attack which happened. It might highlight that out of the total unidentified bodies, 14,305, that is 1,435 bodies were identified on the 14. And out of that, identification DNA was almost 50%. And 500 bodies were identified by team. Around 78% cases were identified. So now we are a country where Nepal, India, so many disasters happen. And Red Cross and ICMR and ICH and various other institutes have started employing. The Red Cross has started employing dentists. Strangely, we are 1.4 billion people and we are not having DVI teams. Recently, we had a commission, and being in the central government, I know a lot of resources will be diverted, and students like you might get employment in that because you are well equipped in dentistry, at least. So, these are the various places where DVI has been used. National history, you must be aware about Nirbhaya. Nirbhaya, Delhi Crime. You must have seen that Netflix series. That was a very small episode where dental tasks were given to Harvard. That's where Dr. Ashit diagnosed what exactly happened. So this was again recently a Walker case. The head was chopped and it was to be identified. So lot of one case can change your entire life. You are in a right place, right time, and your opinion is wanted, and it might be a thing. And of course, research opportunities are enormous. What is forensic odontology? This is the classic definition of forensic odontology. It is defined as a branch of forensic dentistry. Branch of forensic dentistry is an interest of justice deals with proper handling, examination of dental evidence, and proper evaluation of and presentation of dental findings. For a layman or a student, I feel it is application of oral and para-oral knowledge for civil and criminal matters. It is very simple definition. You know, you are applying whatever you have learned in dentistry in civil and criminal matters. That's what forensic odontology is. So, we have scope for extremisha, we have civil rights, we have criminal. These are not at all, and that's our job because we are equipped to tell age, sex, ethnicity from T, and with that, most of the job is done. I mean, if you are able to do ethnicity, if I'm able to do, we have plane crashes. Recently, we had a Pokhran plane crash. A friend of mine, Samarika, actually did that DVI, that is disaster victim identification. And mind you, we just got 24 hours to really pack each and every body and send back. I was lucky to be present. I should not be saying that. I was lucky to be present in Center Forensic Laboratory, Chandigarh in 2016 when Pathankot attack happened. So boxes of bodies come, they have to be distinguished from a martyr and a terrorist. And giving a wrong body can lead to your complete failure of your entire career. So it is very important you are aware about how things go about. What exactly you are taught in dental anatomy, what is the age of the cast? You know, 18 years of age, till 18 years of age, there is a selective. The last tooth erupted is what you decide the age on, right? That is how you decided the age in dental anatomy. So establishing this is comparative, and in a country like India, there is less of comparative and more of reconstructive. Comparative is when you have, please do not, I want everybody to be seated and not disturbing. If you don't feel like you go off. Uh, the comparative analysis takes place where the antemortem and postmortem records are available. In country like India, where every now and then dentist changes, it is difficult to have a comparative analysis. What we have here is reconstructive. So we have lot of job to do because antemortem records are not available. The patient is thinking doctor now and then. So takes place. You should know how to do a oral autopsy, a little gross. But if you are trained as a medical officer or a dental officer, it is quite easy because you are the people who know it is 6, it is 7, it is 8, and you are knowing which tooth is placed where and how the occlusion works. So I think you being a dentist involved in a DVI team will be very handy. So this is a chart. This is the famous Interpol chart. The red one is the postmortem, and this is the antemortem. So antemortem means that you call X-rays from the patient. Like Samarika, there were there were lot of casualties, and many of them were Indians, and most of them from Gujarat. We had to refer back to Gujarat, their dentist, and call for antemortem records, and we had to fill this. And when we fill this and this, and these two match, that means the body is correct. You have a anti-mortem record and your post-mortem record. This can be this is automated also now. So this is the dental age estimation chart. We have recently copyrighted it. Now this actually tells you various methods of dental age estimation. A little smaller. I know it's not visible, but then you should keep in mind there are radiological methods, but just by seeing an X-ray, there are clinical methods, there are biochemical methods, there are, you must have heard about the Gustafson method. There are methods which are radiocarbon dating. There are aspiratic acid method. So various methods are available. And just to be on a safer side, give a range. When you are when you are numbering a cast, we never told you this is a 9-year-old. We always said this cast is 9 to 11 years. This is 8 to 12. Do not be Sherlock Holmes all of a sudden and give confirmatory diagnosis, which might change the life of the individual whom you are giving your opinion on. So this is a journey, and I'm proud that the lower half is dominated by Indians in Demergent, and most of them happened in my university only. We have implemented a dental age estimation comprehensive chart, and that has been tested in various parts of analytic why. If you are postgraduate or a graduate and you want some kind of a research to happen, you can use our chart in age estimation. Only OPGs are required, and not much ethical clearance might be required. Now, this is a very strange and a very controversial topic. People have been behind bars. There's a Project Innocent. If you search Google, you will realize that this Project Innocent, there were people who were convicted on the basis of for no reason, and they were really found innocent on the basis of DNA labeling. So you should be knowing what kind of a teeth mark is there. We should know which jaw moves. We are not crocodiles. We are our lower jaw moves. So we will be pinching by the upper jaw and then cutting through the lower jaw. Right? This is a famous bite mark which I told you, Ted Bundy, the Ted Bundy case. This is the modeling wax on which the everybody please relax. Yeah. So this is a famous modeling wax which is there. We have these two dentists from USA actually took a impression on modeling wax and it used an asbestos sheet which you do tracing on. Just a kind of like tracing you do on. It was photograph of the individual was set on it and he was fixed. He was convicted. Ted Bundy was convicted on the basis of his dental marks, and that was a landmark judgment where he was a notorious serial killer. He was put behind bars on the basis of his dental records. Of course, circumstantial corroborative evidence were there to put him behind bars. You can have a look at quick series which is there. So, if I ask you what bite mark is this? Is this a human bite? No, this is not a human bite. This is bite by a cobra. And this is a human bite. And that too, we have not clicked it properly. The proper click will be this. This is a orientation, and this is the American Board of Forensic Odontology scale on which you have to take a photograph. If crudely, when a constable calls that there is a bite mark, what to do? The easiest way, because he'll not be having an ABFO scale. So what is the easiest way? Keep a coin next to it because that will allow me to remove the distortion. A coin and a scale, regular rulers, So ABFO might not be available. If it is available, it's a luxury. But usually a constable will call from, Regna or, some remote place and the it will heal itself. So you have to take a print of it or you have to take a picture. So keep a scale next to it and most of the things will be solved by us then later on because we'll be using JIT and various softwares to really superimpose the convict, uh, us over the by Photoshop. You're not knowing about Corel Draw. Now this is very handy in these investigations. So did not want you to have a look at such photographs before lunch, but I can't help it. This is next to um, which was the place was near the Shimla. A dead body was thrown. You can see, and then we reconstructed it. And this is my laboratory when it was constructed, and it was found to be. We had an opinion given. I'm sorry, I'm not playing the whole thing, but just keep that in mind. Your computer skills will also play a very vital role if you are a good, good forensic odontologist nowadays. You have to have a skill of, you know how to paint, you know how to really tout, and you can superimpose. That will be very handy in your case. So this is what is my passion about forensic facial approximation. I've been doing it for the last 5 7 years. A lot of investment done in that. What in the 2D you find a skull, you have to reconstruct it. You will use the strength as a framework and you can build the soft tissue structures on it. There are three methods which are there. These are the three methods which are there. Simoves, Gaplev, and Newt's method which is there. Various midline points, uh, 2 points, and this is Shubhendu where I'm saying this is a feedback system where you can fix the skull on the computer. So you can rebuild the nose, face based on the. So our first mission is sort of how to proceed in this. People do ask me being in a central government, I have a lot of secured ways because government supports us. But for a layman or a person who's having a limited resources, how to go about starting in forensic odontology for a dental practitioner if you are already in pass out. I feel I recommend you first of all you should try to maintain records. That is the most important thing. Involve experts. You do not try to be the the best in your field. If you have somebody important, you can involve. You can call somebody from pediatric dentist if you are seeing a child abuse. You can call a person from oral medicine who's knowing more about records. You can call an oral pathologist if you are knowing there is a chance of injury which you want to report. So you can record that. Negligence. See, there is a thin line between negligence and abuse. You have to really understand. And if you don't report, mind you, you can be sued even if you do not report a child abuse in your clinic and you realize that it was the case and you ignore that. You should be aware that even the dentist can be sued for not reporting a child abuse. There is a child helpline which is there. You should report. This is a revised dentist code. You should maintain custody of records. You should be maintaining at least 3 years your records, and if it is a MLC for forever, if it is there, and if people do ask the dentist or a medical record department how many years you should maintain, minimum if it is MLC forever, you have to keep the record till the judgment comes or maybe later on. Uh, Child, this is the child line. You must be knowing about it. If you are knowing the child abuse, any kind of child abuse is there, you can dial that number and get the thing. Now, how to proceed for students? Most important, many of your students will be thinking how to go about in forensic odontology because it appears a fascinating world. But what is my future and how do I target myself? Uh, Most importantly, training. You should be trained in is a good dentist first and then go for extra training because if I see the neonatal line which you learn, every year everybody learned first year neonatal line, and it's a very big important thing in a forensic setup or scenario because that will be deciding there was a stillborn or a line preview because it will be deciding there is a prenatal and a postnatal anatomy there, and if you find neonatal line, the entire thing changes because our law is like that. Killing a baby, aborting a baby, there is a difference of entire judgment. 3 years and life imprisonment. Female feticide has its own problems. A country where women are worshipped, and in a state where the skewed ratio of ladies is there, and then you might not find women even in Haryana. There's a skewed ratio. So this might be a very handy neonatal line. And if you talk about various other canine dimorphism. So I can go on. I mean, if you are trained well, I can go on and discuss so many aspects of dental anatomy, metric and non-metric traits. And you might feel that it's a Eureka moment. I have learned this, but I did not know the application. For 7, 8 years, even I was not knowing that I'm teaching neonatal line and it has application in forensics. So I will suggest you that you should download a 3D software in your phone, which can tell you what a teeth anatomy is. It's available. 3A is a app, and you can take and you can rotate the teeth. I have started involving in my carving classes, downloading that software so that you are tell instead of opening a wheeler and seeing a 2D thing, you can see a 3D thing, and you can evolve yourself in that. So India abroad, there is training. There are, see, if I start enumerating, we recently conducted in Jamia Millia certificate course in forensic odontology. We have various associations which are there. IGA training is there. I learned in IBFO, that is Harvard. Dr. Ashit is there. Then there is training in Maulana Azad happening. There is training, various associations. JSS Mysore is there. Gujarat Forensic Science is there. So you name it and you will get it. It's you who has to train yourself and get yourself equipped. Abroad, yes, Dundee, Adelaide, uh, FBI, Interpol, you can go anywhere you want, and a lot of investment, of course. That's my book. On this platform, I promote. It's good to brag your book, and that's a book, and that's a chapter in Schaefer's, which is there now by Asif. So you can go about if you're really interested. You can really read about the politics and relations. So these are the expressions which I invite you to join in PEFO if you want. I'm General Secretary of Indo-Pacific Academy of Forensic Odontology. If you are really interested, you can join. We have a platform to really. I see students really. We have scholarships. We have fellowships which are there. So if you are interested, you can really go about. When I get undergraduates, people do ask me, how can undergraduate be? You are the source of data. We have been doing chiloscopy, rugoscopy, etc. on students only. They set up their own blood group, they fetch their fingerprint, they set up their own teeth, and they take their, if their OPGs are available, if their casts are available, we tend to teach them rugoscopy, chiloscopy, dental age estimation in undergraduate itself. And mind you, in DRDO, we have two recruitments from our college because of these trainings which happen. If you search V Jain, Vanshika Jain, P Kapoor, Priyanka Kapoor, A Chaudhary, Aman Chaudhary, that's me. If you search, you will realize that DRDO employment happened. And now she's doing MDS, of course. But I'm just saying that the sky is open and this horizon is totally open for you to really research actually at undergraduate level. If you need any help, we are always there. You can, I'm 24/7 available on email. But mind you, you should have a good research machine. For clinician researchers, many of you are postgraduates and researchers who really want to know how to go about train your students, train yourself. College, keep it in mind, you have to have a green, red, and yellow, what to take, what not to take in your research program. Multidisciplinary approach, we have ASUDRs, Arizona State Dental University caste system, anthropology and dentistry, orthodontics and oral pathology, oral medicine and oral pathology. So I never sat alone with oral pathology and wrote, and that's the reason highest and higher citations I have than my contemporary in oral pathology. I'm not just bragging, I'm just saying that a little ahead on multidisciplinary can lead to a lot of citations in your research work. Try to use software if possible if you would require. This is the ASUDR. We recently had a Lancet publication, Springer Nature publication on this. Uh, this is various, we disseminate knowledge. We have been taking CDs, workshops all over the globe. The workshop on rugoscopy I talked about. This both the charts have been invented in my university. These are rugoscopy, chiloscopy. We have published everything which we cover. We are very eager about publishing, and we know that anything data we have, we try to publish it as soon as possible. Uh, these are all forensic odontology. You can imagine these are not only PubMed, they are high impact journals. And a little ahead, why? Because the horizon was open, nobody has explored yet, and I invite you to really go about studying. So go ahead. You need to see, there are, as I said, there are associations which are looking for people who are trained. When I travel abroad, Leuven University is looking for scientists, PhD openings, sponsored openings. India itself, who does not have a DVIT yet, will be exploring. And with NDC, this as a subject, of course, again, openings will come up. So I think right now the bus is static. Once the bus start moving, you will not be able to catch it. So with this, these are the cases. With this thing, I have just to brag about my grants and see, being in a central government, it's quite uh, you know I'll not say easy, but if you are moving, government supports you. These are the future automated tools which we are planning in forensic odontology, and we are quite open that you use any of them from us with a proper prior permission from your university and our university. Thank you so much for your patient list.
everyone. Am I audible right now? Well, I am Dr. Saurabh. I am from Sri Banke Bihari, heading the oral pathology department there. And today I am here to speak on a very, very important topic. And today we'll realize how important and pertinent it is for you all as young graduates and postgraduates. Oral cancer. We all are seeing patients day in, day out. We are into clinical postings, we are into clinic, we are seeing patients, but what are we concentrating at? We are concentrating at the heart tissue. But today we are going to concentrate and learn about the soft tissues and a major problem which is associated with the soft tissues, that is oral cancer. So before we go ahead, just all of us, I think, Bangalore have read papers about oral cancer, most common presented oral cancer. And with management, that is a new life. And surprising is that oral cancer is not being given that much importance in our day-to-day healthcare planning that is being carried out. So in India, cancer with a oral cancer. See the data, we see the impact, they how to diagnosing the early and to us taking the program. See the picture and textbooks, and I'm sure you will be clean. But the problem is when we encounter such patients, we do not know what to do with it. And we may panic and The patient is expecting us to do something with it. But at that point of time in the clinic, maybe answer doesn't go ahead how. We knowing how to go ahead, what's the first step, what is the second step, what do I tell the patient, what do I promise the patient, how to go about it. So whenever we see such a patient, whenever we see such patient, we should be alarmed. Now, luckily, oral cavity is very good instrument when going to give explanation, and this oral cancer does not do the overweight. It is a multi-step process proceeds through a pre-management, pre-management training before developing an oral cancer. So it's a long process and commonly associated with the heart. Now, oral cancer is the most common malignancy affecting the oral cancer. Malignancy. This whole disease process is pioneer survival. When I was a student 20 years ago, then it's the finest. Having progress is not present here. Now the problem is not in the diagnosis different. The problem is different who is coming to us to bring them free. हमने बहुत कुछ सुना है कि कैंसर पेशेंट्स में भी डॉक्टर जुड़े हैं कि हाँ ये आई तो आपको जिंदा प्रोग्रेस है before we go ahead, what oral cancer and what damage it causes, the etiology and the cause findings. Now, surprisingly, unlike other cancer, oral cancer is a type of cancer that it is totally avoidable. At least 90% of the cases, it is avoidable because it is the patient who has himself been addicted to the habit. So we have to handle the patient. When the patient is coming to us, we have to enlighten that an addiction and disease. You will see. Okay. Can easily overcome this with quit the habit. Any kind of treatment is successful only if you quit the habit. If you keep on giving him any medication and he still smoking or using all. Now, what are the common physiological reasons? We knew that it's associated with the habit of smoking tobacco. So, what is there in tobacco which is causing oral cancer? It is nicotine. And nicotine alone itself more than 4,000 of byproduct chemical after combustion, which is causing this change in the cells of the squamous epithelium. Now in India, this problem is even more specific. Whatever literature we read in our time, it was mostly Western country. Now in India, the problem is more specific, deal with the more specific manner because here the patient is also having the habit of smoking along with smokeless tobacco, which is very unique to see on the quantity where the patient is having the habit of chewing gutka, supari, tobacco, okay. Normally, alcohol is a contributing agent, synergistic effect in the formation of oral cancer. Now, we sometimes see a case of patient, for example, of these patients who never had any habit. Still, she develops oral cancer. So, the third most common or recent advancement in etiology of oral cancer is the human vaccine against is also effective against development of oral cancer. Getting only two strains which are responsible for cervical cancer, along against which a multivalent vaccine has been developed. So again, the etiologic agent is preventable. No vaccine will prevent development of oral cancer. Other predisposing factors are there. For example, patient is having the weakened immunity, immunocompromised, immunosuppressed patients, vitamin A deficiency. The predisposing factors which predispose the patient to any transmissibility. There are certain genetic mutations which can be carried from one generation and can be expressed in subsequent generations. Actinic radiation, UV exposure can also lead to genetic changes, but all these are minor in the Indian context. We are talking about the Indian scenario. In the Indian scenario, it is smoking, smokeless form, alcohol. Now, very interesting fact that oral cancer is more common in males as compared to females, but this number is now increasing in females as well with the increase of HPV. About 95% of the cases occur over the age of 40. This number has come down. Earlier, when I was a student, this number was 60. Now it is occurring more and more in youngest patients, younger individuals. 1 in 4 individuals who are diagnosed do not have any predisposing factors or risk factors which can be added. There's something which is going on for years and years with it. All forms of tobacco and heroin, all forms, any form, combine together and have a synergistic and synergistic effect. More than 50,000 Americans are diagnosed every year. It kills 1% every hour in America itself, where we think that the healthcare is well developed, diagnostic things are well developed, patients are aware, educated. So only thing which can prevent is regular checkup. What is the point if the patient has already getting cancer and then you are diagnosing? There's that you have diagnosed the patient at the early age. So we have that window where we still in the old production management disorder stage. And if you diagnose him in that stage, you can give a very good life to the patient. That is where you can make a difference. So I do it. This topic is relevant to all of us. We are examining the oral cavity every day of every day. That is for what stages are the earliest stage. Now the WHO and the global cancer statistics in 2020 are giving the statistics based on the population and the income statistics of the world. So if we see here, 18% of the population lives in the Indian world. We are 1/5 And we lie in the medium human development index. Human development index is an index based on the infrastructure development, on the per capita income, on the facilities which are available, and we lie in the medium HCI index group. Now, if we see here, this oral cavity cancer is maximum in the Indian subcontinent, which is lying in the low and medium HDA. If we see the region-wise incidence rate, again, Indian subcontinent is the capital for the incidence as well as the mortality in terms of human oral cavity. Now, this is a recent newspaper cutting which was published on the World Cancer Day on 4th of February of this year in India. And the incidence of oral cancer is young. Now, the, the region specificity of oral cancer vary within the Indian subcontinent also. We get vast country. So, if we see here in the eastern region, oral cancer is something in the month of the northeastern region, the common strains are some. In females are very, very high. It is roots. But India, in Andhra, showing the value is very, very high. In seeds, we will also developing multiple cells in the brain. All these things we have to keep in mind. Now, what about non-smoker? Here, there is the global statistics and India ranking very much high around where but farmer the exposure is the uh, my picture request to all of you is when you examining hard tissue, I know you are having trained to examine find out the cavities for all of you to examine. Look at simple changes which are very easily made on the oral cavity and you can tell the patient that I am able to see completely like normal. That is, if I talk from practice point of view, practice management point of view, patient will give you more credibility that you are looking for something more that you are. But problem is that punch and you send it for microscopic examination, that is the gold standard. But the disadvantage is associated with biopsy, that is the main. And may come to you with multiple problems, multiple reasons. Now, which area to biopsy? This area, we don't know. So, this is the patient called as swing cascade. Patient who is obviously having the habit, which is developing frequently. Teachers may have molecular changes which may be happening. Various fractures are on. Okay. So these currently are able to technique vital thing where we can use the time already to highlight the cytology, the non optical imaging techniques, we can use handheld devices just like a handheld expertise. So the first vital thing is already me. Very simple. We have to use just 1% here. It's very much because easier to select the side of eye. The sides are taken up the maximum these blue color, blue choice of. What is the point if I go back and take on the India? Very misleading. So collecting the biopsy side is very important. Other same look I think that is taken up by the regional say the that we change. Both of these have shown to be higher sensitive and diagnostic as compared to visual overlay. Third non-invasive technique is exfoliating oral cytology, where we just scrape the superficial mucosa with the help of a cytobrush or a tongue plate. We smear it onto a slide, we fix it with an ethanol spray. All these are very easily available. All these tricks are also very easily available, very cheap, very inexpensive. Just use it only for 1020. The rapid result within an hour. We can make multiple slides, we can do multiple stages. You obviously have the help of the audiology department, and you can see different features in different states. For example, I can see here the nucleus and cytoplasm showing changes. This plastic changes in this cytoplasm. Map stain can be done to different layers in different color card, denoting different layers of stain in the paradigm. Fifth thing, which is specific for fungal hygiene. That can also be used for people say the need for constant. Now this web psychology now today in the era of AI and practical AI. So this technology also can with seeing very portion of थोड़ी सी लाइट पर changes which have happened within this so you can see here with a small red lesion on the dorsal surface of the tongue. This is through naked eye, but the margins, the extent of the lesions are not very clear. And when it is exposed to this well scope, so you can see here all the normal tissues are highlighting into green color, whereas the lesional area is being dark And you can compare the size of the lesion and the margin of the lesion. They are highlighted well using this well scope, just utilizing this technique. Another optical imaging based system is chemiluminescence, where it is utilizing the property that when the light is to a cell, different light shines to negative. The electrons are excited to a higher. When it comes back to a ground state, the energy. Okay, so this is called as chemiluminescence, in which when the light is incident onto the cell, the electrons within the cell they jump to a higher cell. When they come back to their original cell, to stable position, the energy is very important. So this is another trademark product called as switching effect. So, prime product can be used to reacting chemical metabolism and is producing. If area is normal, when the area is abnormal, the same principle, light is being emitted, so by the cells, they rise to a higher cell, compared to the normal cell. That's the concept. Okay. So these are now the steps we have to detect oral cancer. Right. The any available market. Care by okay, so first is DNA methylation biomarker. DNA methylation is an epigenetic change. Okay. Changes its okay. So what we detect is or what we detect is the DNA in the DNA methylate it with the DNA. Methylate it when it is when nuclear changes when happens. The ratio between unmethylated and methylated certainly be altered. So after collecting the sample, it could be just either in DNA. It could be just a staining from another response. To detect methylated level which is going this manner. Such molecule which is target is it in the mode. Getting future that in the specific. Reverse getting. So using the method to find the release what you will be touching this molecule will increase over time. Team bio possible for initiation of tumor and increasing the stem cell has property of stem cell. For example, in embryological stage. So what happens in this area or like the CD4 to expression increases. So there is a lower expression of CD1 in the software. Because the better there, here the expression will increase to the important form. So the next level, the quantity in some extremely early stage. That is what we want to time. At the early we never want of fail into like ये मॉलिक्यूल बड़ा हुआ है इसका मतलब दैट पेज पे ये पूरा पिक्चर के लिए सेलेक्टिव एलिमेंट निकाल रहे this molecule is overexpressed then it means that we have a mind checking out the patient. One patient you don't know what is happening. You know this molecule element marker which can tell you that smartphone based imaging system technology that was high sensitivity specifically from insulin. Obviously, it's not going to replace everything, not going to replace the oral pathologists. It is going to bring up what the info office is going to tell you suspicious and non suspicious. As soon as it comes into the suspicious category, you know that it's written. So there are a lot of studies which have been done, and there are artificial neural networks. The sensitivity of 18 to 96% and it's very high. Now there are a lot of things also the physicometric device which is electromechanical system. So it uses a lot of advantages of biotechnology while electromechanical systems, small circuits are ready. So we put a sample, everything is within the scale. So we put a sample, we put a cylinder, we, we know the targets. It could be a DNA, it could be a and it is going to detect any of these microparts. It could be nanomaterial, it could be antibody, sign, capsid, and it is going to use the microfluidic technique in the form of mass and it's going to rectify it. On a small portion of the cat completely automated process, even which requires laboratory personnel. Can do a wide range of diagnostic tests because it is requiring a very small sample. There's very much limitation of reagent consumption, the process, the reproducibility, the reliability, and very little important how much all this that I have been talking for the last half an hour Okay, this is not really but this is remaining now also. These are mixed with with RNA based things with these kinds of tests themselves voluntarily. So with increasing awareness, a lot of studies being going on, all this is not reality. All the lab tests that we were studying during our time are now turning into a reality. It is now turning non-invasive. What can we clarify this working? So,
Request all students to please be seated. Please.
Yes, sir. Where? Wait. Yes, Anne. Thank you.
Sir, answer was Sam. Anmol Bagaria. Here, similar culture with us. Here, it's similar. I would like to request sir to please looking for a lunch. Sir, हमने बना लिया ठीक है टेंशन अगर डालना है तो क्या करना 2 दिन में बनाएंगे
सर खुद ऐसे बोल रहे
सुनो कितने बजे स्टार्ट होगा?
यहाँ पे कोई लैपटॉप चार्जर है कि नहीं? हाँ हाँ, कौन ले गया? कौन ले गया? यार इसको दिया है। हाँ मैंने चेक किया है। हाँ कौन सी फैकल्टी और नहीं कर दिया तो मैं किसको ढूंढूंगी?
हाँ, हटा देते थे, बताइए। भाई कौन से टॉपिक का क्लास? ये वाले हो गए, ये वाले हो गए। बारिश थोड़ी है ना, वो उससे अरेंजमेंट करवा दो, तो वहाँ अरेंज कर दो। जल्दी कैसे कहाँ बैठ में वो आएगा लैपटॉप गिर जाए।
I there was no
Okay, okay. Yeah, fair. हाँ, सही है, अभी अभी सही है, अभी सही है। Chairman, good afternoon, everyone. I am Pavitra. Hi, everyone. The master of ceremony for today will run all our respected dignitaries, all our speakers, HPs, respected faculty members, and students to the Bachelor's program of Eminent World Mental Services and Rural Reform. We will announce access to various classrooms and scientific events. We started prize distribution for scientific events with knowledge and moving on for the distribution of the country and places. And I would like to call you on the stage. Dr. Ashish Chandra sir and Dr. Anmol Bagaria. For in mission and breakthrough. Today, Hanuman, Ravi Sanchi, Radha Krishna, and Riddhi Better. Chairs and knowledge humans. And we have the research about the main item with a electronics bomb. For solar stream, we have Subharti now. Shantari, Shantari and Vishnu. Vincent Bunsen and Shyam Sarvati from PDS first year. For the next category, that is solo dance, we have five situation for Dr. Pavitra Rastogi ma'am. Remove your Pandita Jain. Please first proceed. Category, I would like to call upon the stage Nishin and Ampesha under the category dual dance. Would like to call on the stage Dr. Mantina, Dr. Yasser, Dr. Cohen, Dr. Cohen, Dr. Paran, Dr. Neena, Dr. Jasmina, Dr. Anushka, Dr. Ekshna, Dr. Rajshna, Dr. Sindhya, Dr. Wilson, Dr. Manasina, Dr. Shrestha, and Dr. Punana. First on fashion show participants are drawing for a group photograph on the stage. Thank you very much, sir. For the scientific time distribution, I would like to have a writing lesson.
What kind of? It's like very closely as a part of everything. And I'm sure you all must have felt happy with at least. Right? Start. easy presentation first. So that easy paper presentation. In section 1, first prize is by Dr. Shivali. She is Dr. Dr. Rastogi. He also was one of conservative to Bharati and College.
सामने सर बिल्कुल यस फाइव मैम सामने टेस्ट करो बरोबर सामने ये क्या वेट करेंगे मैम राइट क्लोज आने सामने ग्रेट थैंक यू
Second prize is by Dr. Anushka. She is PG Department of Pediatrics, Protocol and College, Maharashtra.
यस कौन सा पावर है ये क्या फाइव ग्रेट थैंक यू
For PG paper presentation section 2, first prize is by Dr. Swami. She is again PG Department of Pediatrics, Protocol and College, Dr. Pavitra. What Department of Pediatrics? By Dr. She is again from Protocol and College.
यस सामने में यस तो क्या ग्रेट फाइव ग्रेट
In session 3, first prize goes to Dr. Raj, Dr. Ayush, Department of Prosthodontics, Sharda Dental College, but I think it's clear. And Dr. Akshita, Department of Cohen, ITS Dental College. Both of them I think. Okay. Second prize goes to Dr. Saroj Nayak from Subharti Dental College. Dr. Nancy, Popular Marketing. All posting professional clean staff Department of Temporary Cement College. The next session, first prize goes to Dr. Nakshi and Dr. Charlie, Department of Health. Second prize goes to Dr. Ria and Dr. Brahman.
Second prize, first prize was in the Department of PhD from 41 College. Pharmacy and Dr. Science. Department.
Yeah.
Action Dr. Nishima from Kalka Dental College gets the first prize. Dr. Anjali and Dr. Manasi from Subharti Dental College, they are not there. Now we start with the UG paper presentations. So, in the under the category of UG in paper presentation, first prize goes to Sejal Sharma from Subharti Dental College. From Subharti. First prize is backed by Tarun Sharma. Also, there was a Tema. Vaishnavi and Simran. First prize is to answer
First prize to Bhavya and Mansi. Lastly, the last sentence, first prize to Heather. Okay. Presentations. First prize, first thank goes to Arpil and Alina. Ideally, delivered.
Second prize is to Ronald Dent. First, Cohen Manishwari. Kanya from Ram 121. First prize goes to Prem and Ravi. Prize goes to Apar, Sri and Mandri. Sorry, So let us have a huge applause for all the Now we would like to start with the felicitation of organizing members. I would like to call Dr. Sumit Goyal sir on the stage. Dr. Kathleen Sharma sir, Dr. Ishaq Mukherjee, Dr. Nanda Mahendra, moving further with the organizing members, I would like to call Dr. Ojasvi Sharma sir, Dr. Shvedra Kundwal sir, Kamsi Rohila, Shreyansh Bhatnagar, Dr. Manpreet Kaur ma'am, Samriddhi Singh ma'am, Rashid Bhatnagar, Subharti Garg, Indian Raj, Smriti, Gaurav Batra sir, Gaurav Verma sir, Dhruv Singhal sir, Dr. Indra ma'am,
Samriddhi and Manpreet, we should.
Dr. Sanshra, in number of Highland, Highly Hypothetical. Dr. Nidhi ma'am and Dr. Anjali ma'am. Thank you so much, everyone. Award for organizers of Leonard World Music School and Olympic Conference goes to Subharti Dental College. For all the faculty members from Subharti Dental College, please select the award. Please give us a Dr. Meerut. Presenting the awards are the leader grand cards for leader academic partners.
We all think grand conference being organized uh, under Dr. Anmol, who is the CEO and organizing chairperson, and Dr. Ashish, who is the organizing secretary. And I think only few of us know that how much hard work they've been putting in since last 3 days. University में already एक university program and like बहुत support university नहीं मिल पाया for that program. Still they managed to conduct such a big conference. Always they are encouraging to everyone that we can see. And I think we all will stand and give an applause to whole team CynoDent, especially to Dr. Anmol and Dr. Ashish. And for the grand conference side also, like she said that they go to learn and planning position and yeah, and one of the things and she really now very ready. Complete. Once again,
What I did, I don't remember. Strongly, complete, I don't remember.
myself and Dr. Abhinav and
But Russian, Syan, Adam, or Russian from in Rajasthan. Which I was maybe Adam to what is the estimate? I like Russian. You should have been better.
It's very hard. Absolutely. Yeah.
founder.
Thank you so much, sir. Thank you so much, ma'am. Now I would like for Dr. Smith to mention what is technology. We can start with the call to do a global map.
Well, in organizing it, I start with our principal, Dr. Swami. He conveniently he has agreed and given all these support in conducting this conference. Uh, Without his support and blessings, this would have not been possible. So thank you, sir. CEO of CynoDent, Dr. Anmol. I mean, I don't know how many of you know her personally, but what I think she's the most elegant and most humble person, and one of the most humble person I have met. And she is a formation such from minimum design skill done. So how perfection is our field working, and thank you so much. And we are very calling me together. So they will be the beginning of our education and we will be working together. Dr. Ashish Chandra, I know Ashish since long time. He's from my specialty. And again, he is one of the finest person I know. And he is so student friendly. He is always supporting students. Actually, he's like, sir, आपने कम awards दिए हैं, हमने और awards देने चाहिए. Then we were like, बस हो गया हमने awards. All the head of the departments of Subharti Dental College, thank you to them for their support. All the faculty members who are in the organizing committee, Dr. Abhinav, he's my friend, he, yeah, whatever he said, he's always there to support me. Without him, बहुत difficult होता है, बहुत सारी चीजें organize कराना. He's always has the uh, all the students of Subharti Dental College, without whom it was not possible. Thank you for participating. Thank you for registering. And I'm sure you people must have learned a lot in this conference. So how many of you agree that what I told you that this will be a learning experience? You present something, you will, and especially to the conference portal, how many of you will agree that what I did was right? So this is what was required, and I'm very happy. Few of you were there all the time during the conference. I can see that you have supported also nicely. कुछ लोग तो कह चलिए प्रोफेसर लाएंगी सुनते नहीं है पर कोई बात नहीं जो सुनते हैं अच्छी बात है. Then the organizers, I mean the team has worked hard, and I thought I'm going to say something about the article that Subhati students बहुत अच्छी हैं. And especially the work they do, tirelessly they are working. This when this conference started, मुझे सबसे पहले बोला था कि मनप्रीत से, नहीं तो मनप्रीत तुम संभालोगे conference बहुत मुश्किल काम है. Please help me. And then she was like, sir, आप बोलिए जैसा आप बोलेंगे हो जाएगा. So she started with the registration process. और हम सक्सेसफुली बहुत अच्छे registration करा पाए. And every time I think मनप्रीत से मेरा I mean, she is my student, but इतनी बात तो हमारी कंपनी में है. Sit here, wait, and you are very nice one day. इसको मैंने बोला था पूरे टाइम आपको अनमोल मैडम और आशीष सर के साथ रहना है और उनका पूरा ख्याल रखना है. And I hope he was 15, 16 months since my life was 200%. So he also deserves. Family also she I can see that she also worked very hard in doing all the things. All this communication was there. So and I was really happy when the inspiration by how she handled the last part when music was not playing and then she started singing and that was very nice. Two two people and Dr. Sakshi. जिनसे शिकायतें पूरी नहीं होंगी शिकायत तो हमेशा रहेगी.
but I love them very much. So my second thought, NA, because they are very good. All the other students, Palak, Evelyn, like you are doing great job. I तो अभी भी खाते होंगे, but चलता रहेगा. Subharti, Smriti, I mean all working students on there. हिमांशु मतलब all these people are like कि बस एक काम हो गया बाकी ये लोग काम करते हैं गौरव श्रेया अभी तो गर्ल्स के स्टूडेंट्स ने भी बहुत अच्छा काम किया श्रेया रक्षित I mean there are many I can't take all the names but Gaurish sorry Gaurish I mean Gaurish
Yes, so all the cases of the program.
right maybe the good thing because those are the really Gaurish for looking after it but you don't think that and Dhruv, Dakshin, Bhanu and Dakshin. I mean, these are all very good students and I'm very fond of them. उनको पता है कि मैं नाम भी ये हूँ. Very, very nice. And इससे तो अभी संभाला मैंने पहले आदमी पहले तक कोई हाइब्रिडेशन में था होते हैं. I number for it संभालने अच्छी बात है. And that is good. And one thing is for my hippo Akash. ये लड़का कहता भी है कि फादर का नहीं किया और एक push class. Where is this class? It's in eminent soon. I have no words for you, Swami. The way you handle everything is superb and there is many things to learn from you. The सब एकदम expertise के साथ आप संभालते हो and that is very very much. Thank you. You are so great. Well, my कोई कंप्लेन नहीं पता नहीं कैसे मैनेज कर रहे हैं मेरी मेहनत की वजह से Thank you so much for inviting me. And not only from Subharti, as Secretary, IDM Vivekanand branch, thank you so much to the whole activity. Yesterday, to support us, many of the IDM unit came. They were there in the board function, and they were looking very happy. Many of our members came in the pre-conference and announcement also. They were very impressed with this, and they also said that we should do this more often, and we will do it. Surely. So thank you, everyone, and thank you. And the administration of Subharti, without their support, this nothing is possible. The campus, whatever we have, it is because of them and their support. Thank you to them.
Now, I would like to call Dr. Bagaria to bring similar scientific findings in fields of activity. Good afternoon, everyone. I think Sir has stated most of the days, so I'll make it very short because I'm sure you all are very tired of keeping 3 days of continuous efforts to this document. Even this one week will be. You know this because we don't want you to miss anything and whatever the lecture you can attend, how much of it hands-on you can attend. So to give the maximum things, the time is very short. So firstly, I would thank God for blessing all of us with His choices, blessings, and my parents for their constant support. Then I would thank Dr. Nikhil Srivastava sir, who is the principal of this college, and he's from King George's Medical University, and I can see the reflection of King George's in Subharti Dental College. And I can say that you all are very lucky that you are his students and he's guiding you because you think that he will be strict at some point in time, but at the like after 10 years you will realize the importance why and for your benefit what all things he has implemented because we have traveled across almost every college of the country and I do compare anything, but we acknowledge the difference, the change, whatever we see. So, and it is a very big thing that you are under him, and you will always learn many things from him. And also, I want to make Dr. Meerut, both of them are the protein plans to organize this conference. And you know the backbone behind the conference is Dr. Subharti sir and Dr. Gutmann sir. They are sitting right here. And but the part said that Nikhil sir had told for an here. But now I request you all to stand and give a huge round of applause for Sumit sir and Gutmann sir. It's a very nice to have a body secretary like you. And Vedika means a person who can save them from everything. And I think you are the kind for that. I will thank this year who came slightly early. And you can simply and all the management, all the evening and all the members. We have taken in the management in the family. And I'm thankful to all. Thank you. Thank you so much, Ram. We hope of you all enjoyed. I would like to extend our heartfelt thanks to all the respected dignitaries, eminent speakers, and performers. लोग आते हैं जाते हैं हर जगह यही याद बनाते हैं यही सब कामनाएं हैं हमारी ना रहे कोई ख्वाहिश जरूरी हमारा So let us remember that the connections we have made and knowledge we have gained will continue to guide us on our journey towards the path. Signing off. Thank you very much. Jai Hind.